Sherlock Holmes and his faithful companion, Dr. Watson, go on a camping trip. They find a beautiful spot and set up their tent. After a full day of enjoying nature, they go into their tent and fall asleep. Some hours later, Holmes wakes Dr. Watson and says, "Look up at the sky and tell me what you see." Watson is awestruck. After a moment, he says, "I see countless stars." Mr. Holmes replies, "What does that tell you?" Watson considers for a moment and says, "It tells me that the universe is vast, and it will probably take us several lifetimes to gain even a small amount of understanding as to how it functions and what our place is in it." Mr. Holmes asks, "Anything else?" Mr. Watson thinks for a moment and says, "Based on the position of the stars, I would say it is approximately 2 o'clock in the morning." Once again, Mr. Holmes asks, "Anything else?" Desperate now, Watson replies, "Because the sky is so clear, we will probably have a beautiful day tomorrow." Once again, Mr. Holmes asks, "Anything else?" Frustrated, Mr. Watson says, "I can't think of anything else. What does it tell you?" Holmes is silent for a moment and then says, "Elementary, my dear Watson. Someone has stolen our tent." So hopefully, electronic case reporting, which has been a little bit mysterious, will be elementary by the end of this presentation and simple to understand. One of the best things about electronic case reporting is most of the heavy lifting is done by EHR vendors. So I know electronic lab reporting was quite intense for some folks in hospitals and hospital staff, but electronic case reporting should be somewhat painless, I think, hopefully, because EHR vendors have been involved in this for quite some time and have been building modules to do just what electronic case reporting is requesting. So we are going to be covering 3 main topics today. What is electronic case reporting and why should a hospital or healthcare provider participate? What is IHHS's current status for electronic case reporting? And what are the next steps that your facility should take if you want to participate? Case reporting is not really a new concept, and there are probably people at your facility that already participate in case reporting, but may not be familiar with the term. There are essentially 2 parts of data gathering for a public health investigation, which is intended to disrupt exposure or the spread of infectious disease. The initial report, which triggers the second part, most of the initial reports are electronic lab reporting, but once electronic, initial case reporting could be the first receipt by public health or notification that there is an infectious disease in the community. So the initial report triggers the second part, which is case reporting or the follow-up investigation with clinical staff. Currently, case reporting is labor intensive, and for some public health surveillance programs consists mainly of telephone interviews with clinical staff. The STD program also has a form used by many to report some additional information that cannot be communicated with an electronic lab report. This form is generally faxed and is also considered case reporting. The future of electronic case reporting makes use of information already collected in the patient's electronic health record, so that clinical staff do what they normally do without having to worry about taking the extra step of completing a form or answering a series of complex questions from public health investigators. Electronic case reporting consists of 2 components. First of all is the case report, and this is an actual case report that we received on December 9th of 2020. And it can include several categories that align with an electronic health record generally. The second part of case reporting is something called the reportability response. A reportability response is sent to both the hospital or healthcare provider and public health 100% of the time that an eCR message is sent. It contains the condition that triggered the case report. It also contains the jurisdiction or jurisdictions to which the report was sent. And it also includes some links to additional information. In this example, we have a link to CDC's COVID-19 webpage, and there's a little bit of a description there. We could also link to a survey, for example, in a very specific outbreak. We might get indication that there's some specific things about it. I know very early on in the COVID pandemic, there were questions about whether or not a patient who was infected had visited mainland China. Things very specific like that. They may change over time also. So these links will be quite useful if your system can consume them. But right now, in most cases, it's information about the condition. So a lot of times public health will run across strange conditions that are unusual, and we'll be providing information to those conditions within the reportability response. Electronic case reporting is not replacing electronic laboratory reporting, but it is complementary in nature. Also, I will be using electronic initial case reporting, eICR, and electronic case reporting, eCR, as interchangeable terms. Although the first case report might be an initial report, it is possible that multiple case reports for the same person could be received by the public health department. There are many organizations involved with the eCR initiative, but the AIMS platform is the centerpiece of the eCR infrastructure that Iowa and most states will be using. I also want to make a note that IDPH is in transition to merge with the Department of Human Services into the Iowa Department of Health and Human Services. So you may see the public health agency referred to as IHHS or as IDPH, and this is likely to continue for several months. All right. Do we have any questions at this point? I don't see any in the Q&A. So I'll continue on. What is electronic case reporting, and why should a hospital or healthcare provider participate? Let's just walk through a scenario. If I zoom in, I hope you can see this. Let's just walk through a scenario of how public health investigation unfolds at present. For example, on October 3rd, an infant presents at the hospital with bloody diarrhea and vomiting. A stool specimen is taken for lab testing. 2 days later, on October 5th, positive E. coli lab results are released. This will trigger public health to contact the healthcare provider by telephone to ask a series of clinical questions to collect things like symptoms, treatment, etc. The investigator will also reach out to the patient, or in this case, the parents, to gather additional information such as food exposures and symptomatic contacts, if any. In this situation, there are no symptomatic contacts identified, and the child is excluded from daycare until diarrhea resolves and 2 consecutive stools test negative. On October 7th, the public health investigation is wrapped up and the case is closed by local public health and evaluated by state epidemiologists. The last step in the life cycle of the case is a final de-identified update to CDC as part of national surveillance activities. On October 10th, an older school-age sibling presents to the same hospital with bloody diarrhea, chills, and cramps. The healthcare provider diagnoses E. coli and treats the sibling, but does not take a specimen for lab testing. It is possible that public health may not learn of this sibling's infection, or if they do, it may be after another person is infected and they're identified as a symptomatic contact. That is what current surveillance looks like. So let's take a look at this scenario again if electronic case reporting were fully implemented. In the future, the same key events happen with some additional automated actions that both provide information to public health responders more quickly, but also fill in some reporting gaps that currently exist. Quickly walk through the new items in red on the calendar. The infant presents on October 3rd, but the October 5th lab results trigger not only ELR, but also an eCR report to public health. Local public health should still call the healthcare provider to ensure that the patient or family has been informed of the diagnosis, but it should be a very brief call because the clinical information has already been shared electronically. The steps on October 7th, wrapping up the first case, remain the same. However, the October 10th visit and diagnosis trigger an electronic case report to public health, which in turn initiates an investigation for the now symptomatic sibling, just like the original investigation on the infant. This additional case report could actually disrupt further spread beyond this family. So there are two major benefits of implementing electronic case reporting. First of all, significant time savings at both the clinical setting and public health. More complete detection of infectious disease in the community is the second major benefit. Okay, so how does all of this work from a little bit more technical perspective? There are really three main players: the hospital, and I'm including the vendor-supported EHR system in that category, the AIMS platform, and public health. The AIMS platform provides several services. First, it maintains the reportable condition trigger code set. It's a nationwide set, including all reportable conditions reportable to any jurisdiction in the country. For example, varicella or chickenpox is not reportable in Iowa, but it is in Wisconsin. Varicella is part of the trigger code set that everyone will use. Secondly, the AIMS hosts the reportable condition knowledge management system, and this is where reporting rules for every jurisdiction are maintained. Thirdly, they provide an interface for public health jurisdictions to author rules that align with their reporting rules. So, for example, varicella will not reach Iowa systems, but if a varicella report from one of your facilities would reach Wisconsin if that was appropriate. The AIMS platform automatically routes eCR messages to the appropriate state public health jurisdiction. This means one reporting channel from your facility reaches all public health jurisdictions nationwide. So, which is a very nice feature. I know we're currently working with a system that's near a border, and we maintain and will forward electronic lab reports to other jurisdictions when that's appropriate, but we only really do that for the conditions that are reportable in Iowa and a few others that are reportable in the states around us, but we don't really have a natural loop in what is reportable in other states. So we can't really facilitate reporting to every other state. At the hospital, the fully functioning EHR first consumes the trigger code set and flags qualified records for a case report. The EHR generates the case report in the HL7 standard format and transmits the eCR message via direct secure messaging or another XDR protocol to AIMS. It is also possible to collaborate with Sync Health for this transmission. At public health, the eCR message is consumed into the central disease surveillance system shared by all of the public health jurisdictions in Iowa. So we have 99 counties and 2 city jurisdictions. So everyone will use the same centralized database and will receive those same case reports when it's appropriate for their jurisdiction. I do want to share a quick note about business associate agreements. Since IHHS is not really performing any activity on behalf of hospitals in the eCR process, it is not likely that there will be a need for a BAA between IHHS and any hospitals, but the AIMS platform is actually working on behalf of hospitals, so there may need to be a BAA if your organization so desires. I also need to make a quick note that neither electronic lab reporting nor electronic case reporting are intended to replace immediate reporting, which is a telephone call. Electronic reporting simply cannot beat a phone call from a healthcare provider suspicious of one of these infections. These should still be set up for electronic reporting, but phone calls are the required reporting method if any of these infectious organisms are suspected. Are there any questions at this point? I'm not seeing any in the QA, so I'll continue on. So what is IDPH IHHS's current status? Officially, we are ready to receive. This is from the IDPH webpage, the Promoting Interoperability Program, formerly Meaningful Use webpage on the IDPH website. And you can see electronic case reporting is down here. We've been ready for a couple of years, actually. IDPH is capable of receiving eCR messages But we have paused all ECR messages for 3 reasons. First, we didn't see any real ECR messages until we were deeply involved in the COVID-19 pandemic. And by then we were just keeping up with a massive influx of data, including ECR. We could not automatically consume ECR and could not keep up with the reports manually. So we didn't actually build the bridge to the IO disease surveillance system at that time. We just didn't have the resources and didn't have the time. And then in 2021, a decision was made to replace our current IO disease surveillance system. So we will be building that bridge in the future, but we are not quite yet ready to do that, but it is coming. As you know, there are many independent projects at hospitals, EHR vendors, and here at IDPH. The plan is to keep pressing forward on all fronts with the idea of landing many of these projects together so that when we are able to flip on the switch, there will be some ECR traffic flowing statewide, hopefully. CDC and AIMS are able to move forward with the hospitals ready to onboard while we are paused, and we don't want to prohibit you from implementing ECR if you are ready. Are there any questions at this point? Okay. Go ahead and move on. What are the next steps that your facility should take to participate? First, I've got a disclaimer. Hospitals and healthcare providers need to determine for themselves how they need to comply with the promoting interoperability requirements. While we may have general knowledge of these programs, we are not experts and can only provide general guidance for meeting the objectives for any particular hospital. Here's a possible next step option, though. If you have not registered yet for electronic case reporting, you can do so from the IDS page on the IDPH website. There is a PDF version of the ECR registration question set. It is likely that multiple areas will need to be consulted to answer all of these questions. So we've got if you can navigate to the IDPH website and just search for IDSS in the A to Z index, this page will be the first thing that pops up. And there's a promoting interoperability section, and we've got electronic case reporting prominently displayed on this page. There's a video explanation of ECR, and here's the PDF version of the question set that you can download and use to prepare for the online registration. And the online registration is really what we want you to do, is to complete that survey. Possible next step is if your facility is ready to move forward and begin onboarding, you can send an email with the subject of ready for EICR onboarding to our main electronic email address, elr@idph.io.gov. Onboarding is facilitated by the CDC and the AIMS platform folks. They do want the referral to come from IDPH. So we have a couple things to check before we make that referral, but you would want to just send this email to us for the second option if you're ready to move forward. We also have a web page. It's not ours, it's the AIMS platform's web page. What is ECR? And they have different pages specific to healthcare, EHR implementers or vendors, public health agencies, as well as HIEs and networks, HINs. They all kind of follow a similar pattern in how they're organized. They have an overview of how your particular facility type fits into the whole electronic case reporting process. They've got a readiness and implementation checklist and other steps that you can follow through and learn about. Are there any questions about that? All right. So the facilities that can be onboarded now, I believe, are Cerner customers primarily and Epic customers. And I know on a previous session, someone had indicated an intent or desire to maybe get together an Epic ECR group, and I would assume the possibility of possibly a Cerner ECR group as well. I am hoping to I am thinking that I can send that out in the Q&A document, a way to organize that, and I could help facilitate setting those up. Any thoughts about that? Okay. Well, that actually ends our presentation today.